Okay, so yesterday I think we ended up showing this case of postoperative gliosis. So why don't we start with this case today? Oops.
Okay, so sagittal and axial images of the cervical spine. So prior surgery, anterior fusion surgery from C3 down to C7 probably, with post-surgical changes, edema and increased signal within the spinal cord, and a lot of atrophy there.
So, in the case of post-op gliosis, probably due to trauma to the cord at the time of the surgery, though sometimes this could be trauma to the cord due to whatever accident the person had. And I don't know whether this fusion was due to a prior accident or not.
So that's good. If there's volume loss in the cord, then we can just ignore that signal then? I mean, do we have to at least raise a question of acute on top of chronic injury? Or?
The gliosis in the neural system is bright. It's basically gliosis is scarring and the neural elements, and it tends to be bright like this. So it tends to be stable with fairly sharp margins often.
Yeah, it is sharp. That's what I was wondering if that's enough just to say chronic gliosis period, move on.
Right.
Thanks.
I mean, the history, going over this too, there's no history of any recent trauma here, just the prior surgery.
Okay. Well, this looks a lot more kind of focal and I wonder, I mean, could this be like a focal syrinx maybe?
Yeah, so this is a focal syrinx. In this particular case, this patient actually had surgery at this level. So this was thought to be a post-op syrinx, so you don't see the surgical changes here, but the patient did have surgery at this particular level. Okay. Shiv, what do you think of this one?
Okay, a couple sagittal images here, and it looks like there's a fracture of the C4 vertebral body. It looks like an anterior teardrop fracture, and narrowing of the spinal canal at that level.
And yeah, great, good. Okay.
Okay, so we have two sagittal views of the cervical spine. There is abnormal signal at the level of C3, C4 in the cord.
And we have all these disc protrusions. So this is something that people have feared for a long time, and it caused a lot of people to have surgery. Was a concern that disc herniations in the cervical area could press upon the cord and produce ischemic changes of the cord, and then basically dysfunction at that point. So this drove a lot of surgeries. Over the last 20 years with MR, we've seen a lot of cases where discs have pressed against the cord, deformity of the cord, and they go on and become very chronic. And it turns out that it's extremely rare that if that's all you have, that you go on to gliosis or injury to the cord. So just doing surgery because you have a disc protrusion that butts the cord is no longer considered itself sufficient. You have to have adequate symptoms to go along with it. And that pressure alone, most of the time, probably does not induce cord problems. But there are situations, and so one concern is that if you do have a disc protrusion here, if you have any sort of trauma to the cord, to the cervical spine, you could get abrupt narrowing of the space here and contuse the cord. So that's really the issue. But that seems to be less of a factor driving fusions now than it was 10 to 15 years ago. But beware of it, that it certainly can happen.
So two sagittal images, anterior listhesis, C3 on C4, and multi-level disc protrusion with increased signal within the spinal cord.
And we see the right here. So generally, when you see signal within the spinal cord like this, it's highly associated with symptoms. Even though you don't see it on T1, we do see it on the T2 in this setting. And the cause for this is not exactly at a disc level. So why this has occurred is somewhat unclear, but there's obviously a lot of instability of the cervical spine here. So presumably it's some sort of a traumatic injury to the cord caused by instability. So here's another case where we can see some disc protrusion. They were concerned that this disc protrusion was affecting the cord at this level, so the patient went through a fusion, and you can see the cord signal looks a little bit better after the fusion, though I don't think that the patient's symptoms improved. But what's generally thought to be the case is that the symptoms typically don't improve a whole lot, but they stabilize and they don't get worse.
Well, on that last case, the one before this, that was a transected cord, right?
Well, on the T1 weighted image, you see that the cord doesn't look like it's completely interrupted.
I see.
Just on the T2 weighted image. And so this is a case where it looks like it's transected on one image, but it wasn't completely transection. The patient was not quadriplegic.
I see. Okay.
Okay.
So this focal canal narrowing by that disc, this postoperative changes, and oh wow, on the axial, there's a little, I guess, an extrusion, small extrusion there posteriorly. Yep.
So it's a central focal
narrowing of the canal.
Extrusion.
Yeah, okay.
And it's abutting the anterior aspect of the cord, but at this level we don't see any cord changes. So this is right above the fusion, so it's an area of increased risk for stress and strain. Just 1 second. This is John. Hey, John. Did you get the email? I sent you an email. That's very nice.
Sorry for the interruption.
Oh, that was great. Thank you.
Okay.
You want to tell us stuff like that.
Single axial view through the cervical spine, and it seems that there is a subdural collection.
So this person came in with acute back pain, but no history of trauma.
Okay, it looks like there's a subdural collection compressing the cord more on the left and right.
So we can certainly see there's something. There's the cord. This is abnormal. I'm sorry. And then here's what the sagittals look like.
Okay, so there is like a heterogeneous collection posteriorly displacing the cord.
And so here, it really looks like this collection has a nice, sharp interface here, and there's some fluid separating it from the cord. Right? And then, but here we can see a lot of inhomogeneity.
Yeah.
So what do you think this is?
I think it's hemorrhage. It's epidural.
Which space?
That's Yusuf. That should be epidural.
Yeah, it's outside.
Well, that doesn't. Well, I was going to say, does it look infectious? And obviously not.
Yeah, this is pretty typical of hemorrhage. Yeah. Now this actually was drained surgically, and they confirmed that it was an epidural space.
Was that a spontaneous one? Or?
Yes, that was spontaneous. We had no. I don't know. We don't really have a source for it, so it was just called spontaneous epidural hematoma.
Some people are on anticoagulants or take a leave and thinking that it's not innocuous, and a leaf can make you bleed pretty good.
Okay.
So there are a lot of ways people forget what they took and how things happen, but a lot of people take non-steroidals and wind up with hematomas.
Okay.
Okay, so 84-year-old female with fall, unmoving bus, hip replacement, PE, and commodine. So extradural space, extensive heterogeneous fluid collection throughout the thoracic spine.
And here it also looks like you may have some fluid, kind of a smooth border with fluid separating it from the cord.
Cord, right. So cord is being compressed. And again, I believe it's from commodine.
So there's the cord there, and here we can see a
right.
nice, smooth uh, basically membrane between the abnormal fluid collection and the cord and the CSF. So it's another epidural hematoma.
Right.
Okay. So there's a fracture through the vertebral body, and I don't know what else. I mean, it might be affecting the posterior elements? Could be like a chance or component chance fracture.
Well, she's being lifted up by a caregiver. And severe osteoporosis.
Osteopenia.
And basically a very rigid spine. And you can see the fracture through it.
This patient needs more than a caregiver.
So we were talking yesterday about DISH and how you need to have 4 vertebral bodies or 3 segments fused for the diagnosis of DISH. And for those of you who aren't here, in this issue of radiology, they came out with a very nice article from Utrecht, I think, the Netherlands, where they looked at CT scans in people of the chest and a large number of people, and they found they had CTs 5 years apart and were able to see people with DISH and go back, and they had something like 50 cases of individuals who had the criteria for DISH, 4 fused segments fused by the anterior longitudinal ligament, and then they went back, and 5 years before they did not have those segments fused. And they, as you might expect, what they found was that there was really kind of a gradual fusion of those anterior segments, that there's no magic that happens when you get 4 vertebral bodies fused together, and that kind of the pre-DISH or early DISH really just looks like degenerative disease with hypertrophic bone formation at multiple levels that then kind of coalesce together. And then the editorial with it had an argument that it's basically just a continuous process, and there's no magic between when you have 4 vertebral bodies involved versus 3, as had been kind of described in the prior literature. They didn't really have any correlation with other manifestations like hyperostotic changes at tendon insertions and so forth. But they said it was a strong case that it's really kind of a progressive, more of a degenerative type phenomenon.
Well, once you get to be 60, in general, there is a fusion effect of the spine. You start out at age 14 with instability, and then you go to not instability, but oh geez, I guess I'm sorry to forget.
Stiffness.
I forgot the name of the damn thing. But anyway, there are 3 phases in life. You start out with the spine moving in every direction. Then you get
Ankylosis.
degenerative disease, and then you get instability, and then you get stability at the end. And there's a lot of overlap. I can't remember the name of the guy that came up with this, but it sounds very reasonable. That folks, this patient is probably 70 or 80, I would think, probably a female.
Here's the MR scan.
So there's an overlying hematoma. It's strange because on the axial X-ray or CT there was also large bilateral pleural effusions, but probably hemorrhagic. But you don't see them on the sagittals for some reason. Anyways, well, yeah, but even to the man when it's touching, it should see it still. Anyways, on the CT. Okay, so there's a hematoma overlying the spine from this fracture, and I don't think there's any retropulsion significantly. The cord seems to be okay. Yeah, there's the fusions there, and
Just remember that once you get to fusions, and especially with osteoporosis, you're at high risk for fracture. Okay, Shiv?
Okay, 15-year-old male with pain after football injury. So it looks like we're slightly off center here. And it looks like in the mid-thoracic spine there's maybe some edema and transverse process of a sort of
What are you talking about?
sort of upper thoracic spine right near your fat right there. Yep.
Okay, right there.
I'm not sure if that's real. Okay.
Axial image.
So yeah, it looks like possibly a fracture or a contusion of the transverse process.
Yep. Good.
Male, posterior neck, soft tissue swelling for 6 months, no fever, wound, or picure. We have 3 sagittal views for the neck, and there is anterior paraspinal fluid collection.
Where's the fluid collection?
I think it looks like some soft tissue thickening anterior to the thoracic spine. Yeah, right. It's going down. Yeah.
I think this is right. Here's the.
Okay.
This is esophagus.
Okay, then we have some edema in the what's that? And the posterior elements. Yeah.
The spinous process.
The spinous process.
Yeah. They're the coronal images, right?
Right, there's some edema around the.
And some people call this a nucleofibrocartilage pseudotumor. And it's just due to, I think it's due to trauma.
Partly.
With hypertrophic change. So, some people call this a pseudotumor because it can be populated as a mass if you have a chronic injury.
Okay, so headache and neck pain 3 months after mountain biking accident. So there's some arrow there.
Okay, so if we look on the other side, we can see the artery and the vein.
Right.
The arrows are pointing here that you're not really seeing the same thing on the right side. This was an MR scan of the cervical spine. Okay. And if you go to the sagittal images, the foramina there for
to see the nerve, fat set pre.
Here we're seeing some flow. There we're really not seeing flow in the vessels very well.
Dissection or something.
Here is the angiogram.
Yeah, we don't see the.
So on this side we have this vessel.
Right, the other side is gone.
That vessel, but then back here.
I see it's gone. Vessel. I see a dissection.
And if we go here, these are the vertebral arteries, and they're right through the foramina there. We can see nice flow on one side, but not the other side.
So it's vertebral artery dissection.
Yeah. So it's really an occlusion.
Occlusion.
The artery.
No, we don't see the whole thing.
Associated with dissection. Right. So easy to miss.
Yeah.
And the patient is presented with neck pain.
No. Trauma is probably going to be dissection, right? In a young patient.
Yeah. Probably.
That artery can be missed, and it has been missed in the past quite a few times.
Okay, so what I'm going to do now is stop this dictation.